They are really, really important concepts in home care system. So here I would like to clarify these two concepts. The first one is the unmet needs. So usually there are many different literatures. They define these two concepts in different ways. So some of the literatures, they actually like to use the activities of daily living, the ADLS, like bathing, toileting kind of stuff, and also the instrumental activities of daily living, the IADLS, like managing medication, meal preparation, etc. This is one way to define the home care needs. There are other ways to define that, like the safety and environment, like whether people will have the full risks, or someone through the cognition function, like do they have memory loss? So there are different ways. So for my today's presentation, the two study I'm going to show you is mainly define the home care needs through the IADLS and ADLS. So the reason why I have to distinguish these two different concepts, the unmet need and unmet needs, because it tells two different stories, especially in policy context. So unmet needs basically captures the gaps in access. So whether people can get the help from the local authority or any other services providers. So if they have the needs but do not receive any needs, then they have unmet need. However, for unmet need, it's totally different. So people may have several different needs. However, some of them are met, but the others has been left, or their needs has been met but not adequate. So the unmet needs actually captures the gaps in adequacy after care is received. So they are really, really different. And also in policy context, most of the government or local authorities, they focus on whether people can access to the needs, but they ignore whether the needs is adequate or not. So then you probably have the other question, like, so why should we focus on public financing only? So shall we have a look at the private one or the informal care or something like that? This is because currently more and more people, older people, they prefer to stay at home. They think staying at home and receive the care is more easy for them to maintain the independence or dignity and also beneficial to their later life, like well-being kind of things. However, many of you probably gonna notice that currently the budgets are really constrained. So government, they don't have many money. However, the care needs to not disappear. So here I've got some statistics. So one is from the Department of Health and Social Care. So their report estimates overall public spending on adult social care is around 27.8 billion in 2024 to 2025. This is a huge number. And a 3% real terms increased from 2023 to 2024. And also each year there are new requests. For example, in 2024 and 2025, there are around 2 million new requests for that year. So things getting worse and worse. And the worst thing is also the councils, they actually overspend their budget. So 80% of councils, they actually overspend the money they get from the government in 2024 and 2025. And also, as we can see here, there is a big fall in publicly funded access. So from 8.2% to 3.6%. So as you can see, here's a big challenge. One side, people's care needs raise a lot. The other side, the government, they have the financial pressure. So then it's gonna create two care gaps. One is unmet need and the other is undermet need. So the unmet need, so people probably have no help at all, or maybe some help being met but not adequate. So as you can see here, public financing actually is the key policy lever. It can shape who can access the care and whether the care is adequate or not. Yes, the slide's gonna be shared after this meeting. No worries about that. So then we did two studies. We trying to see how the care system, home care system respond to the need under the financial pressure. The first study is around it's a comparison study. It's compare England and Ireland during the Great Recession. That one actually is really important, although it's something in the past, but still can link back to the current situation. So as you may know, the current economic climate is not very good, and there are lots of fundings have been cut. So how so we're trying to figure out how the unmet need varies across different systems and during a period of fiscal pressures. And that one can give implications for our current situation. Like, okay, is there any home care system going to be more advantage to respond to that fiscal pressure? And the second study is about the adequacy, especially in England. We're trying to figure out whether publicly financed care is associated with lower unmet need and unmet need among older adults who receive the help. So this is the first study. We use two different data sets. One is the ELSA and the other is the TILDA. So those two data sets are really famous when you're doing the aging research, and they are secondary data. And we limited our analytic sample to the people who aged 50 plus, and we mainly focus on the Great Recession period, which is the 2009 and 2011. So here, so both countries, so the England and the Ireland, they both experienced the economic recession. So for Ireland, the financial crisis led to the Troika bailout agreement in 2008, and that one requires a large reduction in public sector spending, which include health and social care. So by 2014, around 10,000 health sector staff lost their jobs, and home care services saw a 12% budget reduction between 2008 to 2011, although there is a rising demand. So this is a really big loss. The budget has been cut down a lot. And England, they also experienced the economic recession, and they also did some cuts to the health and social care parts. So the social care spending had increased between 2001 and 2009, but fell annually through 2014. At the same time, the eligibility became more restricted, which limited access to publicly funded care. So the way they deal with the financial crisis with the fiscal pressure is different. And also the home care system is different. So for England, the publicly funded social care is mainly the responsibility of the local authorities. So the local authority, they deliver the help. The older people, they are assessed in two ways. The first one is a needs test. So the local authority, they assess whether the person's care needs are high enough to qualify for the support. If it's not, then they're not gonna give support to that person. The second, there is a financial means test. So they also assess people's income, savings, assets, and to decide whether the person is eligible for the publicly funding for free, or they need to pay some, or they need to pay full money for that. So the public home care in England actually is relatively formalized, but tightly rationed through both needs and financial eligibility. But for Ireland, it's different. So Ireland, the public home care was mainly organized through the Health Services Executive rather than local authorities, so two different organizations. And during the period of the economic recession, the home care and the home health packages do exist. However, the home care was less strongly based on the statutory entitlement, which means the access mainly depended on local services availability and available budgets. So the England still provides certain types of help. However, you have to do two tests, the needs test and the financial means test. But for Ireland, it really depends on the resources, like whether they have the available local services or whether they have available budgets. So that's home care system is different. Then because they do experience the same thing, the financial recession, but the home care system is different, then we have a question. So we would like to see when the economic conditions become more difficult, do the older adults care needs translate into unmet need in the same way across countries? You probably have a hypothesis here. It probably gonna be different. So yes, they are different. So this is our first finding. So as you can see here, the unmet needs actually was common and much high in Ireland. I think you pretty can predict that before I show you the results. So in England, the 38% of the people who report unmet needs in that period. However, for Ireland, it's 66.1%. It's really huge. So that one actually give us an implication. The unmet need is not a margin issue during the economic recession. Actually, the economic recession can widen the gaps. This is really, really important. The second implication is about the country tax context. The country context actually matters. Different home care system actually gonna affect people who can receive the care or not. So this is really, really important. And also, the other thing is that when we study unmet need, we should not only focus on individual factors like living arrangement, whether they have formal help or informal help, and their disabilities. We actually have to look at the system level things like the home care system. So maybe the person lives in, so one person, if they live into the other country, maybe the situation is different. So they may have more unmet needs or they may have less unmet needs. It really depends on the system. And then we found some other things. It's really complex. So we found that individual resources did not solve the problem. And we found actually for Will's physical needs and cognition, the findings really complex. Some are even counterintuitive. So for the Wills, most of people, they assume that, so if you have more wealth, you are a rich person and you definitely have less unmet needs. However, in our study, we did not find any protection against unmet needs in either nation. So which means even though you are a rich person, it doesn't mean you will get more help. It really depends on the system, the home care system. So if in the country, within the country, they only have, quite limited resources, like they only have a couple of service providers, and you have to pass this, and to get the help. And then whether you have money or not, it doesn't matter. And for the physical needs in Ireland, activity limitations were linked to greater probabilities of unmet need. That one actually is kind of quite straightforward, and which means even though you have more vulnerabilities, it doesn't mean it can automatically translate into adequate support. And for the cognition functions, that's a little bit counterintuitive because people probably going to assume that, okay, so if a person has poor cognitive functions, probably they're going to have higher unmet needs. However, in England, this is something definitely different. So if a person who has poor cognitive functions and then they have lower probability of reporting unmet needs. So that one actually links back to the home care system as well. Because in England, if the person who has poor cognitive functions, they are more visible to the service providers and to the carers. So then they're going to send someone to their home to solve their problems and help them. So that's the reason why they have lower probability of unmet needs. So yeah, there are some findings really, really counterintuitive, but if we think about the system level factors, then it all makes sense. So here, I also would like to emphasize the point when we study unmet need, we really, really need to take the system level, especially home care system, into account. So the first study, we had a look at did someone get care? Then the next study, we mainly focus on whether the care is enough or not. So the second study, we focus on England only, and we use the ELSA data again, well, wave 6 and 9, and we limited the analytic sample to people aged over 58 plus, and the period period we focus 2013 to 2019. So here we use two different models. The first one is longitudinal fixed effects logistic model. So you don't need to know what kind of this model. So we use these two different models is because we try to answer two different types of questions. The first question is about the types of home care. We try to compare publicly financed home care, privately paid home care, informal care. So which one is best? Which one can effectively reduce people's unmet need and undermet needs? And the second research question, we're trying to look at the transitioning. So we kind like to look at, so when people transition from publicly financed types of home care to the other two forms of home care, what's going to happen? Is that going to affect whether they can get the help or not? Is that going to affect whether the care is enough or not? So this is the main questions we would like to have a look. And then we found something really interesting. So for the public financing, actually it was associated with reduced unmet need. However, for undermet need, it did not work. Okay, so here, it actually makes sense. So if you think about the policies, especially local authorities or governments, you probably kind of get that sense. So most of the policies, they actually focus on the first part, whether people can get access to the care, the help or not. So they try to cover as many people as they can and try to provide help to them. But whether it's enough or not, they try to ignore that. However, we have to take the adequacy into account. Why? Because if somebody they receive certain types of care, but the other, they have the other care needs, that one has been left, or they receive the care but it's not equal, then in later life, it's gonna cause a big problem. The new needs gonna arise, and then there cause some other issues. So what these two studies means for the policy and research. I think the first one is about the adequacy measurement. So we really, really need to distinguish the two really important concepts, unmet need and undermet need. We really need to care about whether people receive adequate care or not. And also we have to protect access during the economic shocks, especially the current economic climate. As you can see here, the budget has been cut down. So how are we gonna prevent this pressure and how we're gonna satisfy people's needs? This is really important. And the third one is we have to look beyond eligibility. So we have to think about whether the help is good enough, and we have to pay attention to the intensity, quality, and fit. So here, I think some of you may have some different opinions. So you're probably gonna say, okay, yeah, we have to look at the adequacy. Yes, we need to see whether people get the enough help or not. However, as you mentioned before, the economic climate is not very good. As you can see here, the government they actually under a big budget pressure, and the local authority they overspend their money each year. This is a big issues here. We don't have unlimited resources, and we're trying to help people. So what we can do is to cover as much as people we can, provide help to them. However, whether it's enough or not, maybe it's a luxury. We can't do that because we don't have resources, money, staff, etc. And also, some people are going to say, okay, for adequacy, that's a really vague concept because you know, two different persons, if they receive the same care package, they probably gonna say different things. For example, person A. So he has someone to support, like he lives with his spouse, he has family support with meals and reassurance during the day. He only needs to help with washing and dressing. And person B, he also needs with the washing and dressing. However, this person lives alone, and also he needs something else. if the two persons receive the same care package, they're definitely gonna say different things. The person A gonna say, okay, it's really helpful, it's adequate. The person B gonna say, okay, I still need more, it's not adequate. So how you gonna assess whether it's adequate or not? It's really subjective. So then people gonna say, okay, we're not gonna do that because first of all, we don't have unlimited resource. Second, we don't have a standard criteria to assess adequacy. So how are we gonna do that? So here's a question for all of you. Do you think we should pay attention to enough care? Is that you think it's a luxury, we should ignore it, or we actually have to take that into account? So I would like to hear your opinions. So if you have any opinions, you please share with me. Okay, I'll give you several minutes. Anyone would like to share?
I can share from personal experience if that helps at all.
Thank you.
So it was during COVID, but my mother came to live with us. She lived abroad and she came to live with us because we couldn't continue looking after her where she was living. And before she came, I had spoken to a couple of care companies and they were open to providing care for her. And then just when she arrived, they phoned me up to say there was absolutely no care at all, and they wouldn't even be able to offer, a few hours a week because all the carers had walked out. In the end, she went back to her country where, I mean, the issue there was that the carers were leaving her and I wasn't in the house, so she was left alone. But in the end, she went there because there were people available, even if they weren't adequate, as opposed to there not being anything at all. Social services had come round and had said that they potentially would offer to pay for 4 to 5 hours, I think, but she was pretty much blind, diabetic, and had touches of dementia, and I had a health problem, so I couldn't physically, fill in. So probably we needed more than that anyway, but it would have been a starting point. But then I looked round to see what there might be able to be provided. We live in a rural area and it was looking unlikely that we'd get very much. Our doctor told us that in the area, people were ending up in care homes because there weren't people to come home. I think that was meant to be even before COVID, but in a rural area, I think it can be worse. If we were in the towns, there would have possibly been more people available. We were told of a couple of private carers that were attached to our GP surgery, or the local community knew about, and one of them came round and she might have been able to help. But she was visiting, 2 or 3 other families, so you sort of really had to fit in with her as well, even though she would have been private. I have to say she was very nice, but she came in and it was during COVID and she had her mask she had all her credentials, but her mask was not covering her mouth and nose properly. And when she came in at a subsequent occasion, I left alcohol gel out for her and she never used it. So I wasn't, very sure who was checking on her, and there wouldn't have been anyone to go to. So that was a personal experience. It was some years ago. I know it got better, but I think in the rural areas it is still quite a problem. So from a family point of view, it was a really big issue because, what do you do? So anyway, yeah.
Thank you so much for sharing. And also because she didn't do it properly, so probably it's gonna cause the later on issues. So that's the reason why we talk about whether we should care about enough care or not.
Well, and
So yeah,
if you have an agency or company, you can go
yeah,
back to them and say, this isn't appropriate. But if there's nobody else, then what do you do? So yeah.
yeah, that's a big issue. Thank you very much. Anyone else would like to share your opinions?
I mean, I'm quite interested in, so my PhD was around kind of patient-reported outcome measures and experience measures, and I think they're something, particularly experience measures, capturing those kind of experiences of care that people receive in as older adults is kind of really important to kind of actually understand those kind of nuances that make kind of the same care for different individuals kind of really kind of important to understand, which I don't know if we're doing very well.
Yeah, exactly.
I don't know.
Yeah, exactly.
Yeah. Can I just comment there? I
Yeah, please.
also think it's about the juxtaposition between what is available and what the choices are. Because sometimes the choice might be that you kind of live with the unmet need as a person who needs it, or you make a choice to forgo living in your own home, for example, and to then move to a different setting, and that might be a choice that you're not willing to make. So it's measuring not only what the unmet need is and what the need is, but also then what the alternative is from the older person's perspective, and whereby that line is different for everybody, which is basically, so enough, it isn't enough, but is it just enough? And I don't really ethically think that we should be just giving people just enough. That's not what I'm suggesting. But what I'm suggesting is that line between what is enough for an individual to keep them, that balance between what they need and actually what they want, which is quite interesting.
Yes. Dominic, would you like to comment? Oh, you mute yourself.
I wanted to comment on something based on what Teresa was saying. Teresa, I hope I pronounced your name correctly. One of the problems with this country, from my point of view, in terms of choices, is that if you give up your home to go into either independent living or a care home, it's not where you're going to end up. You don't move into it and know that that's where you're going to stay. Suddenly, if you go into hospital, or suddenly if you develop dementia, or whatever, then they have the right to just say, sorry, you can't come back. And then suddenly, I mean, I know of a number of people around here who've ended up in limbo, because of a hospital stay, and not being able to, they then move from one place to another, which is disorientating enough at any age, but at that age is even worse, especially if cognition is beginning to fade. And on top of that, you have no control over, you've got to know a few people and they can look after you well, or they can't, and then suddenly you're somewhere completely different. And when you're not feeling well, the last thing you want is to be being moved. What you usually want when you're not feeling well is to crawl into your own bed in your own place. So I think if that were to change, then people might be more willing to give up their home if they got to that point, as opposed to feeling forced in it, because you'd be leaving something possibly to have, more hands-on care, to have more socialization if you're on your own. But if you then know that you're going to end up in limbo, I think it's a really big barrier for a lot of people. Anyway, that's just an opinion. So
thank you very much. Thank you. Yes, I think sorry, carry on. Okay, good. I think all of your opinions are really, really valuable. And yeah, here, as you mentioned, so it's really, really hard for us to decide what is just enough and enough. So adequacy is really, really hard to define. So then here's the other question, is that how to measure the unmet needs? So currently, lots of policymakers and the researchers, they try to use the hours to measure. So they believe, okay, longer hours means the care you receive probably is going to be adequate, but actually used hours alone may not actually capture whether the care is well-timed, reliable, or high quality, or even good fit for the person. So we can't just use that. Then the other researchers, they criticize that, okay, so currently lots of the qualitative studies and quantitative study, when they talk about adequacy, they try to use the self-reported assessment, like the people who receive the care, they report whether it's adequate or not. However, some research they think is really, really subjective because it really depends on the person's preference, experience, etc. So should the adequacy be only judged by the older adults themselves, or should we actually include unpaid carers, the professionals, or by the outcomes, such as the safety and well-being as well? So like a multi-dimensional assessment. And also, because we don't have unlimited resources, we really need to think about whether it's a cost-effective adequacy. So this is something really hard at the moment. So what level and what type of support? So this is a really, really complicated question. And I think for the future research, we actually have to think about how we're going to measure it and how we're going to uh, test that. Do we have a standard criteria? So here, I feel like, so the whole environment, like the policymakers and also the researchers and all the whole societies, they should actually make efforts to investigate these issues. So Dominic, you have a question. Does the measure feedback about adequacy varies depending on the quality of care and how long each care visit can last? For that question, so if you talk about the qualitative or quantitative, so for most of the quantitative research, they mainly or only focus on the hours, because lots of the quantitative research they based on the questionnaire, and in the questionnaire they only ask how long each care visit. They don't ask any other things. But for qualitative research, sometimes they can get some feedbacks from the adequacy varies. Yes, I hope that's okay, good. So for here, for how to measure unmet need, I also would like to hear your opinions. So do you have any new ideas or something or maybe fabulous ideas you think how we gonna make it a standard assessment and how to measure the unmet need? So if you have any opinions, please share it. And also you could comment on that. So do you think it's feasible? Do you think it's doable? Can we actually measure the unmet need? Or no, you think that's not a good idea? Like to okay, somebody type on the chat. Good. Anyone would like to share? So for me personally, I feel like adequacy is really important. Currently, yeah, that's true. Currently, we are studying below zero. Yes. 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 I think Dominic, your comments really really valuable. Yes, we actually have to make it more visible to the policy making process and make the people to really notice that adequacy actually is a really, really important thing, and we should make it a starting point. And also for the measurement, I think it's a really complicated questions and also issues, and there's a long way to go. So yes, starting point is a good point. Thank you very much. So this is today's presentation. So if you have any questions, please ask and really welcome. And this is my contact email. So if you would like to chat, discuss about the topic you're interested in or collaborate with me, so please email me. Thank you very much.
Thank you so much. I mean, yeah, to that last kind of slide, what's your kind of take on that? Like, what's your thinking about?
For that one, I think when we measure unmet need, I don't think we can use only one dimension like ours. We actually need to make it a multi-dimensional concept. We actually have to look at, okay, the quality, intensity hours, and also we need to do a bit of quality research, like ask the older adults feedbacks. And also we have to include different stakeholders' perspective, like older adults themselves, unpaid carers, professions, and everything. So the unmet need measurement should not be a one-dimension thing, should be a multi-dimension things. And also we have to consider about the costs as well, because the budget is really limited. Thank you.
And what Teresa, have you got your hand up?
I do, yeah. It was excellent talk. Thank you, Faye. Really thought-provoking. And this isn't really how we can measure. I mean, it's really difficult, obviously, to measure unmet need. This is the problem. But also, we don't. I think thinking about what happens when we don't meet need. What are those other costs when we don't meet need? And then people, think other things happen. So they might then need another service in the
Yes.
NHS, for example, a fall, a broken arm, an ambulance, all of these things. And how do we then count or measure that? So how do we quantify undermet and unmet need by not just how much it costs to receive those things, but also by not meeting those needs? And I'm sure there's lots of research on that I don't know, but I think that's really important, is the counter cost, I guess.
Yes.
And
That's
what data is available on that, because I guess you then need to use other data sources and put those and look at those. Yeah.
Yeah, thank you very much. This is really, really important points. Yes, some research, they try to look at the outcomes, like you said, the hospital admissions. So they try to get the hospital admissions data and try to connect the two data sets together and do a test. Yes, I think that, yeah, this is a really important one. So the same thing. So unmet need measurement should be a multidimensional one. So we like you said, we need to consider whether the receipt of the care is enough or not, and also what is the outcomes. Okay, so Dominic, you have a question. Are you aware of countries where needs are adequately met to measure against? So currently, I haven't noticed any country they say, okay, all of the older people's needs are fully met. No countries can say that, because it's really, really hard to satisfy everybody. And as you can see, nowadays it's the aging speed is really, really fast. So more and more needs arise each year. So that's the reason why the government, they try to cover as much as people they can, and they try to ignore the adequacy. Hope that answers your question. Okay,
Yeah, it does. There ought to be a benchmark for the minimum,
Yes.
at least, though, hadn't there, for what's acceptable as a basic. Yeah, but thank you. Yeah.
Okay, good, great. Any other questions or comments?
I'm just curious where you want to take this work next. I think with what you found out from this study, what are you hoping to do, or what the questions that you're left with that you'd like to kind of take forward?
I think it's the how to measure the unmet needs. So probably that one gonna be my next project or something. So I think this is a really complicated one. So maybe that's the reason why I call for any collaborations. Good.
And I think, it's a really kind of interesting space between kind of care and care needs and health needs, and that blurring, which kind of adds a kind of extra kind of layer of kind of multi-dimensional kind of complexity for you. But it'd be lovely to hear what happens next.
Okay, thank you. Definitely keep you posted. Thank you so much. I think, that's my presentation. And thank you very much for everyone joining this and I hope you enjoyed it.
Thank you so much. Anyone else? Any other questions? Otherwise, I think oh, and your drink of choice.
Oh, drinks of choice. Yeah, what I sent you, drinks of choice.
Yeah, I think it was a stout, which I thought was a very interesting choice.
Yeah, stout. Nearly forget. Yeah,
They
stout,
do. They do. Yeah, I like the zero Guinness is kind of a good.
Zero Guinness.
It's a good strong kind of which I've kind of taken to recently. Which is, and I know Amy, you like I saw you drinking a stout. Oh, you're a Guinness. So there you go. It's very much appreciated.
Yeah, super. Oh, that's great. That's great.
All right.
Maybe we should. Yeah. Go on.
Well, we've recorded. I'll stop recording. Actually, we've recorded